So we're going to talk about intake models today. All they really want is you. How many of you are doing traditional triage? I'm talking about the nurse up front, doing the vital signs, doing the initial assessment, traditional triage. Anybody got some things that even you will admit seem ridiculous? Like, are you doing spouse abuse screening, HIV testing screening? What the heck? How did we get doing those up at the front of an ER visit? I mean, intake and traditional triage has morphed into something that we never intended it to be. So we're going to sort of challenge that and show you some new ideas for intake. Little background, the case for why you should improve this. You know, when I go in to help an ER that's having trouble as a consultant, I focus on door to doc because it's low-hanging fruit. It is so easy to make some improvements there, and there's a lot of bang for the buck. And so I've done this many times over and over. And I'll tell you about a grant that EDBA had last year from AHRQ to look at different intake models. It was the best time I've had in my life professionally. So, perfect storm is brewing. This is real data, though it looks fake. This is showing you that the acuity of healthcare needs and the intensity of those healthcare needs increases as you get older. It's kind of a duh. But there you have it. It's an article from Sprivilege that just shows you. So this means as the baby boomers hit, we're going to be seeing patients that are older, sicker, on 20 medications with lots of comorbidities. It's going to be a challenge managing them. Oh, and by the way, in case you slept through this now, more patients that are in the hospital in this country this very second pass through the ER than getting there any other way. So we really are the front door. So in case you were a skeptic and thinking, well, there's other projects I want to do in my ER. I got some other things I want to do. I want to make the case for you that I think this is a really good place for you to be focusing, and we'll march through it. We used to talk about crowding, overcrowding. I like to call it overcapacity. This means that the majority of ERs every day, usually starting around 3 or 4 o'clock, have more patients than spaces to treat them in. Overcapacity. Anybody not overcapacity? Anybody? Usually it's the very small, low volume ERs that will tend to have enough bed space 24/7. But even that's changing. And then we aren't talking about overcrowding too much anymore. We're talking about flow, right? I like that. Flow is solutions. Overcrowding is the collective whine about our predicament. So I like this. And we're talking about, can we use data to drive improvement in performance? And as you saw from Suzanne's talk, oh boy, we are going to be doing this. So if you thought this is way far off, it is not. It is very close. Some things are being demoed right now in terms of these time intervals that we'll be tracking and submitting data to CMS. This may be one of the most important things in your little booklet, and this is from an article that's on the Annals web. And I'm not sure, I might have missed it, it might already be out, but this was from the Performance Measure Summit held last year in Salt Lake City, 2010. It was put on by EDBA, and people got together to once again flesh out the definitions of things. If we're going to be measuring this data, let's make sure we're all doing it the same way. You are aware that there have been hospitals that would boast very short door-to-doc time because they didn't count the waiting room time. What the heck? I mean, we all need to be measuring it the same way. By the way, ACEP's Quality and Performance Committee has bought off on most of these definitions. ACEP's Council has bought off on these. ENA has bought off on these. So we're trying to all at least be giving you the same sort of information. If this is too hard for you to read, I know it's Lilliputian in your book, just email me and I will send you the article itself, the PDF. But what we want to show you is there's timestamps to an ER visit, and the time between the timestamps are the intervals. And you will be tracking this. So how many of you have an IT system that is your tracking board for your ER? Yeah, I knew. See, we're more than half, and I knew we were going to be getting there. Pretty soon we'll all have it, but if you're still shopping for it, or if you have one, you better make sure that your vendor's gearing up to give you these timestamps. And as Suzanne pointed out, this whole idea of tracking the admit decision to departure time, which is effectively boarding, that CMS wants and NQF has bought off on, that was dicey. Everyone was having trouble. When does the clock start on that one? Well, the clock starts with your admit decision. The actionable item is you put in an order to admit that patient. You can argue it. Believe me, I've been on so many groups that have argued this, belabored it, like I say, gnashing of teeth. But this is what we finally came up with because we thought it would be less likely to be gained and easier for everyone to play by that rule. So when the doctor puts the order for a bed, the time the clock starts, no grace period, by the way. And mind you, the Quality and Performance Committee belabored this like, oh my gosh, should we have a half an hour to get somebody out? No, at the end it was decided that the clock starts and we'll start collecting the data to see where it is. And my guess is it's going to look different if you're a small ER, medium-sized ER, teaching and trauma center, and so forth. So those are the timestamps and intervals. And as Suzanne pointed out, these are the 5 operational things that NQF has approved. These are marching along, my friends. They're going to be tracking this data and using it to pay you or not pay you. So you really do care about that. And notice door to provider or door to doc, and its cousin, left without being seen, right? When door to doc goes up, left without being seen goes up. And they're going to track these and use these to monitor your performance. And then just above that, decision to departure for admitted patients. So these are the 5 operational ones that are moving along as we speak. And this is unless something's changed, this is as it stands how this is going to look and roll out. They're going to withhold 2 to 5% of the funding that you would currently get. Okay, this is CMS is withholding your funding. And 70% of your payment will be based on how you perform on these metrics that we have been talking about, and 30% on patient satisfaction surveys. So you're going to go back and tell the guy in your group that gets terrible patient satisfaction scores, listen, bub, we're doing this, we care, you're going to play, okay? And this is kind of scary because nobody's like sure how this is going to work. You know, is it going to be press gaining? Who's going to do this? How will we measure it? But this is the scheme as it currently exists. Now this is what is a little bit upsetting. So look at to the far right of this graph. This is your value-based performance. The very far side, if you perform at the 90th percentile, you'll keep the money you're currently getting. Anything less, you will lose. Is anybody sweating? Are you worried about this? This could be a huge chunk, especially I'm worried about the high volume urban inner city teaching hospitals that aren't going to perform so well on all these metrics. What I don't like is if you're a good performer, there's no chance to make more. The game is to take it away from you. So this is how it currently exists, my friends. And don't shoot the messenger, I'm just telling you so that you're not blindsided by it. Okay, when patients walk away and leave without being seen, that is money going down the street, and you should visualize it as such. And these were just sort of rough average numbers. But if you had 3% left without being seen and saw $40,000 a year, which by the way is an average ER these days, working the numbers and making some assumptions, we're going to say $400 for a patient that's discharged. It's way higher in California. You know, there's variations on how much an ER visit generates and how much an admission generates. $1.66 million of lost revenue a year. You do care about this, especially if CMS is going to be taking it from you. You want to get this back. And the best way to do that is to focus on door to physician. When the doctor's seen the patient, they consider themselves in the game. So short door to doc, better patient satisfaction, lower left without being seen, and also actually improved throughput sometimes. Not always, but sometimes. Is the public aware of this? Is everyone familiar with these 3 high-profile cases? I don't think last year you could turn on your computer and not see this video of this woman who is a psychiatric patient in New York City who's dead on the floor. Did y'all see this? It was really, and it was a psych ER, but we were tarred with the same brush, quite frankly. There was a chest pain death that was treated as a homicide case because the woman was kept in the waiting room for 2 hours. And then there was you probably heard this, there was an audio of a woman who's in an LA County ER with abdominal pain, waiting, and trying to get EMS to come take her to another ER. And it was a little bit humorous, except that you learn later that she died. So I think the public is very aware of this, and you know what their attitude tends to be? Fix it. Right? We understand. They're very generous with us in that they understand it's hard working in an ER, what we do is difficult, but they still, the bottom line is, this is your ER, fix this. And this is something that you really do control. So most ERs are still doing a very traditional triage. Now, you might be able to see this better in your handout, but the idea being patient arrives upper left-hand oval, gets seen by the doctor. If you come by ambulance, you're going to get seen with fewer steps, but most have things like back to the waiting room, get your vital signs taken back to the waiting room. In this particular model, which actually is 2 ERs that were in my system, there were like 3 trips back to the waiting room. Anybody operating similarly? I would be surprised if I didn't see most hands go up because most ERs are still doing a very traditional intake process. And of all those steps, which of those steps have any value for the patient at all? This means nothing. They're like, yeah, I understand you guys got to do your paperwork, but I came here to see the doctor. This does not have any value from the point of view of the patient, and this is very old and outmoded. And if there's one thing I want you to take home is, I got to start changing that when I go back. The other thing is, it was designed for lower volumes to be sure, but I want you to keep this curve in mind. This is my curve, your curve, everybody's curve. What you're seeing at 4 a.m. is not what you're seeing at 4 p.m. And that's when this fails us the most, is when we get that afternoon surge. So 20 years ago, 18,000 ER visits, 2 patients an hour, dedicated rooms. Anybody remember that? I was a very excited young doctor going out to practice in 1986. Don't do the math. And my ER had a gynae room and an ENT room and an ophthalmology. Remember that? We were like really excited about that. You were bragging to your friends if that's where you're going to work. That's not the model anymore. It's multi-purpose rooms. Bring the supplies to the patients, and any room will do. Any room will do. So this old model, and where, mind you, they've done studies, and triage can take from 12 to 20 minutes. So can you see on the evening shift how you're starting out in a lose-lose situation? And most ERs, as we said, 40,000 visits a year. We're hopping places. We're Walmart now. And on evening shift, they come almost like mass casualty, almost like, they come in surges. And we control this. The other things, like Suzanne's talking about outflow, we got to play in the sandbox with everybody else. We own this, guys. This is our deal. How do we want to do it? And the way that we've been doing it for 20 years is not really an option anymore. Now, maybe, and this is I'm saying maybe because that's what I really mean about this, if we really staffed it up, but I have yet to see an ER that's staffing up. This is VHA looking at their data for top performing ERs. So most ERs under 20,000, 12 hours a day you throw somebody in triage. The rest of the time maybe she doesn't even need to be there, right? Anybody ever worked in a little ER like that where most 12 hours a day you had triage, the rest of the time you just float somebody out there as need be? That's fine. But look at where most of you guys in the room are, 40 to 60,000. You need 24 to 36 hours a day of triage, plus greeter and tech. And remember how you need them. You don't need it even Steven around the clock. You probably need 4 triage nurses in the afternoon. Anybody with that volume got 4 triage nurses? I mean, if you really cared about service quality and getting them back, that's what it would look like. So at the time of my life last year, I had a grant from AHRQ, Emerging Benchmark Alliance, and Intermountain Healthcare. And it was a year-long learning community. We marched through time, over 40 people, a lot of them leaders in the field, marched through time studying intake, just that. We had conference calls, we wrote a white paper which should be posted on the ARC website soon. It's a comprehensive paper about intake, why it fails, what makes it better, what new strategies are, and so forth. But then we did this very cool thing. We reached out to ERs across the country to try to find people that were doing something different. We had a little poster competition like you see at different conferences. Because you know what, a lot of times the really cool work, it's not being done at academic centers necessarily. Operations improvement is going on in non-academic centers, smaller ERs, all kinds of ERs, where somebody gets an idea like maybe we could do this better, and they're willing to try it. And so we ferreted out some very cool things. And basically, we found that people were doing work in sort of 3 areas. They're changing the space, they're changing the processes from traditional triage, and then they're using technology in very cool ways. So space changes. This is a true story. I hope you haven't heard it, because I think it's one of the most fabulous stories in emergency medicine of a success. And they had to start from a very bad place. It was actually, it's already been presented because they had submitted it as part of the California ED diversion project. But this ER, Arrowhead Regional Medical Center, suddenly became inundated because the other ER in the region closed. So all of a sudden their census just went up. So if you can imagine, they were jamming in 2002 with 58,000 visits. By 2007, 110,000 visits. Could you cope? Would you even want to go to work? I said, give me a gun. I just can't imagine what this was like for them. And they had door-to-dock times of 4 hours. Can you imagine this place? Standing room only. Anybody ever worked in a place like this? There are some sort of large county hospitals typically that are just overwhelmed. They're the only place that people can go that have struggled with this kind of data. Left without being seen of 20%. Would anybody see suites tolerate that today? And as you would imagine, the staff's unhappy. Because remember, if it's that unpleasant for patients, it's really unpleasant for staff, and you cannot keep your nurses, you can't keep your staff. So they decide, we're going to try something different. I mean, they had nothing to lose, right, when you're starting there. And they put the physician, and I'll show you how they did it, a mid-level provider, the provider up front. Now here's some data that I want you to get your mind around. If you let a patient see a provider first, the data is varying. Like Fairfax Inova Hospital, 36% of their patients went home from there. Didn't need to get naked and put in a room and become annoying. Can I have something to drink, right? Well, for some reason, they drove here, but you take their clothes and put them in bed and they're invalids. I have to go to the bathroom. What'd you do this morning when you had to pee? I mean, we really, the world changes when you make a patient an invalid. In any case, they found 50%. I'll show you some other data. The point is, you can count on 35% of the patients be able to go home after they see the provider. So what is that? Mentally, what if you could offload a third to a half of your patients in the ER? Anybody like that? Offload a third to a half, not have them come back. I mean, what a fabulous idea. So they found 50% of the patients saw the doctor, got registered, and went home with maybe some prescriptions or referral, whatever. Another about third had some testing, and only 1 in 5 had to have a bed. And this is how they did it. They had no money, mind you. They brought in these cubicles. The staff set them up themselves. These are from an office supply office store. Because in California, if it's only shoulder height, you don't have to have a building permit. They just did this on their own. And we think this is bold. I think this is impossibly clever and bold. So they made these intake cubicles. Oh, what about HIPAA? None of the patients cared. They were so happy. Take me to the cubicle. I'm ready to see the doctor. So here's what happened. And mind you, this is not a randomized controlled study. They were making lots of improvements, trying changes as they went along. But you can still see that as that census went up, as I showed you, they got, by 2008, their door-to-doc time down to 31 minutes. And they're left without being seen in under 1%. I just think that's just astounding. I mean, there's hardly a story like that in emergency medicine where you're going to see that kind of success. But it was very innovative, very clever. Can I tell you, we brought Rod Borker out to Salt Lake City for this conference. The guy is an ER doc who had a good idea in his department. He's not an academic, he's not a researcher, and we made his poster, we helped him make a PowerPoint, and we helped him to present it. And it was a wonderful thing. And most of our innovators were like that. They weren't academics, they didn't have public speaking experience, they wouldn't know how to write an article for Annals, but they had a really good idea that was worth the light of day. So Methodist Sacramento, this is an underbedded ER. 42,000 visits in 15 beds. Anybody doing anything like that? And actually, I think this was Jim Augustine, who you're going to hear from. I think this was his idea to do this. That's the rumor has it. In any case, they said they were going to do something bold. 6 beds were going to be dedicated to triage. And oh, by the way, have you heard the number? Oh, you're going to see 2,000 patients a year per bed. That's how you know how many beds you're going to need. Anybody heard that before? Totally out of date. Jim will show you numbers. Hello, we're looking more like 1,500 to 1,700 patients. What this means is this guy needs 28 beds, at least, right? And he's doing, this ER, they're doing it in 15 beds. So 6 beds set up as triage pods. They put 1 MD, 2 PAs, 4 nurses. The goal, 15 minutes in the triage pod. That's all you get. We're going to make a decision on you. We're roving, making decisions on where you're going to go. And you either go home, you go to the waiting room to get some tests done, or back to a bed. And they brought their left without being seen from 5% to 1%. Here's another vision of a triage pod. Geisinger actually has 5 rooms for intake that the doc goes through, room to room, and calls it one way or another, examines the patient. Carolinas Medical Center, they've actually been doing lots of cool things. They have Barcaloungers. They bring you to a Barcalounger area and do your assessment because they don't have enough beds all day and rooms all day. And they decrease their left without being seen in their length of stay. All right, process changes. I'll show you a few of the things that were submitted. One of the biggest things is getting your mind around this. That bed has about 1,500 minutes a day in a 24-hour period. You can't get more. There's no way to get more. I mean, unless you want to lay 2 people side by side. Okay, that's all you've got. How are you going to use it? And I want to suggest you use it for diagnosis and for treatment only, and then those patients are out of that bed. Remember, 85% are going to go home, right? 85% are going to go home. So keep patients vertical, have some space for them to sit and wait, a diagnostic waiting room, and be more selective about your bed placement. I think we need to rethink the waiting room concept. Okay, this is a waiting room at the University of New Mexico. Boy, I'd really want to hang out there for an afternoon, wouldn't you? Looks very pleasant. This is a veterinary hospital ED. Hey, I could read some magazines there. That looks pretty nice. This is Lehigh Valley, not too bad. This is Intermountain Medical Center, one of the places that I work. But look at this. Would you hang out there? It's like a mountain retreat. This ER, I've never seen it. I don't have a bunch of pictures of it, but they have skylights so there's natural light in the ER. I mean, they've just done a lot of things that are very nice and very aesthetic. So, in any case, Banner Health, playing on this idea that not everybody's going to occupy a bed, does a quick look by the nurse and doctor, and the patients get assigned to one of 3 streams. You keep hearing this model being repeated in different variations. And they improve their door-to-doc times in all 8 places that they trialed it. So I like this because it was fitting for all different sized ERs. Now, Thomas Jefferson did something very different. And when I heard this, I thought, well, why aren't we all looking at this? They have changed their process. They call it low flow, high flow. So beginning of the day, instant bedding. As long as there's a bed, patients get brought back to bed and get assessed there. But sometime, usually late morning, early afternoon, the triage nurse and one of the docs huddle and say, you know what, time to switch into high flow. Then they have an area where they bring their team to the patient and begin a diagnostic workup and an assessment in a little area. Low flow, high flow. Why not? Service industry does this. Like, what does McDonald's do when you pull in and we start to get a backlog in the drive-thru? What do? Like, especially, I used to order those things for my son. Have you ever heard? It's 2 pancakes, syrup, an egg, and a sausage. And the teenage boys love them. And so after a night shift, I would go get 12 of them for my son and all of his buddies sleeping in the family room floor. I'm bottlenecking the drive-thru. So now they have parking space. If you notice this, McDonald's have bought up parking spaces near their franchises. And they say, oh man, would you pull over there and we'll bring your 12 hyenas sandwiches to you in a minute, right? So they've changed what is high flow and low flow. They have different processes, and we can too. Now, to totally tweak the kaleidoscope one more time, in Great Britain, they've totally turned the model of how we process ER patients on end. And Ellen Weber reported this to us at the summit where we were looking at new models. So they were given a mandate, you got to have patients out in 4 hours. 4 hours. And so they were having trouble meeting these guidelines. So what did they do? They decided they'd have major care and minor care. Minor care, you're treated like you're in a clinic. Minor care, you might not have vital signs if you're a healthy person. Minor care, your discharge instructions are given verbally. Major care, you're treated in the traditional way. And they had great success with this. All right, technology can help us too. And I think I've got 5 more minutes. And so I'll tell you about some of the ways that technology can partner with us to improve intake. And actually, this probably would have been a winner, but Ted and Jim submitted this to us after we'd already picked the winners from our competition. Remember I told you we had a poster competition. These are the guys that first reported on barcoded lab specimens. Anybody barcoding lab specimens? I think it's almost becoming a standard of care. Who's got barcodes? It's a great way to not lose labs and so forth. They designed a system that would take any data from you and populate an intake or triage sheet. And basically, the patient would sit down and the nurse says, is everything correct? Anybody got a Toyota? Anybody got a Toyota? So when you go to Toyota to get serviced at a Toyota place, they pull up this sheet that has everything about you, where you live, where you work, you know, how many miles are you car, is everything correct? How fast and how efficient is that? Why are we not doing that in healthcare? But they are doing it, and it really shortened their intake. Now, and actually Bruce Janiak is here, so if anyone wants to ask him questions about this. Medical College Georgia, every day like clockwork at 5 o'clock was inundated with ambulances from their nursing homes. They were wondering, was there any way to, you know, not have this be their world? So they started doing telemedicine triage. And I want you to just start thinking about telemedicine, guys, because it really is growing as an option, and it may be our solution to a lot of on-call problems. Telemedicine and psychiatry. The Indian Health Service has been using telemedicine for their remote site hospitals. So in other words, the doctor ain't in the room. He's a state away. But they've even got instruments where you can see the patient's fundoscopic exam with the instrumentation. You can see someone's ear. You can listen to the heart, and the person remotely can get this information. So they began screening patients, and they decreased the number of transports to the ER. And, oh, by the way, they also got ready faster for patients that were critical. All right, could you employ patients and have them triage themselves? Well, actually, people are trialing this. In New London Health Center, the patients will come in, they swipe a smart card, and they enter their own information. They answer their own triage questions. We haven't quite figured out a way for them to get vital signs and get clinically assessed, but they're at least doing that. And it only took 5 minutes. Patients really liked it. And by the way, this is called customer participation, making the patient do some of this work for us. I think it's a great idea. 92% would use it again. And then last but not least, this is the patient access secured system. This is another Carolinas Medical Center thing. So how often is your care delayed because you don't know who the bloke is? They just brought him in from Pioneer Park, he's drunk. Does that ever happen to you? You're like, do we know who this guy is, right? Oh, and the other thing that happens is that drunk from Pioneer Park has 8 different medical record numbers because every time he's come, we didn't know who he was. So they start doing Palmer scanning. It's a bioidentification technique. And guess what? This is who I am. Now Dr. Welch can start treating me. How about that? And what they're also doing is now they're matching up so they know Mr. So-and-so from Pioneer Park who was intoxicated every Saturday night. Now we have all of his records together so we know something about him. And their door-to-doc times are 30 seconds. Okay? So the point is, this old way that we've done things, go sit down with the nurse, she's going to do all this screening, this has to go. And if you would like to know more about this, Steve Davidson and I have written a nice little review. I will send you the PDF if you're interested, talking about a lot of these new innovations that you might want to try. Any questions or comments? Anybody jazzed to go back and try it differently? Anybody need more coffee? Okay, all right. Okay, so next we have Dr. Bucata. Oh, not in the box. Dr. Bucata is going to talk to us about charting solutions. And I'm probably stealing his thunder. How many people are using template charts? I don't want to mention T-system, but who's using a templated chart, okay? Who's using traditional dictation? Anybody using scribes? Okay, ooh, I got to talk to you guys. Okay, what about hybrid charting? Anybody doing that? So it's a template and a little bit of dictation to cut to chase? So I might be stealing his thunder here. He'll talk to you about what he thinks is the best, but if you're just doing traditional, oh, I didn't do this one, traditional hand charting. Anybody? Okay, good. So no one's doing that. So there's lots of new options out there that can speed up your efficiency and, oh, by the way, reduce your risk because you'll document better.